So, to shift into our first C of co-occurrence, just a quick slide on the overall prevalence of this in the community. The NEABPD study, which was really the first community-based evaluation that's include a full assessment of all personality disorders. Prior research just focused on antisocial, has found higher rates of BPD than they initially thought in the community. So anywhere between 5 to 6%, with surprisingly no gender differences between the disorders. So you do see gender differences when you start looking at patients within treatment settings, higher rates of disorders among females than males. But when you look out in the community and include people who are not currently in treatment, there are no significant gender differences. And also that borderline personality disorder, or what I'll shorten to as BPD, is associated with a wide range of other Axis 1 disorders like depression and anxiety disorders, as well as the other Axis 2 or personality disorders. And that co-occurrence is associated with significant disability. So there's two different ways that you can think about or study comorbidity. The first way, which is the way that I've been doing it since I work in research in substance use treatment setting, is to look at the rates of borderline personality disorder in patients who are in treatment for their substance use disorder. You can then flip that over if you're working in or doing research in a mental health treatment facility and look at the rates of substance use disorders in those who are in treatment for borderline personality disorder. So I'm going to just go through and do a little bit of both. When you look across the literature, which now includes over 100 studies that have looked at the comorbidity between these two disorders, depending on which study you look at, anywhere between a half and all patients who are in substance abuse treatment meet criteria for at least one personality disorder. Just talking about all 10 of them for a minute. With higher rates in users of illicit drugs than of alcohol. The variability that you see, because 50 to 100% is a pretty wide variability. It has a lot to do with what drug you're evaluating, what setting you're looking at that in. So settings like long-term residential therapeutic communities or methadone maintenance programs tend to have higher rates of personality disorders than regular outpatient programs. When you look specifically at the two most common personality disorders in substance abuse, which are borderline and antisocial, those range from 10 to 40% prevalence rates. And a key issue of the co-occurrence problem is that if you are diagnosed with one personality disorder, it's pretty rare for you to just have one of them. The average rates for individuals who have a personality disorder when they are in substance abuse treatment, if you're a drug abuser, you meet criteria for about 4. If you're an alcohol abuser, you meet criteria for about 2. So as if borderline personality disorder and drug abuse together weren't challenging enough of a comorbidity, you add on another 1 or 2 personality disorders on that, and you get a sense of not only co-occurrence but complexity, which I'll get into in a minute. These are median rates of borderline personality disorder and substance use. To get a little bit more specific to borderline, about the same rates, around 20% of alcohol or drug abusers. Somewhat higher rates in the inpatient programs and the outpatient programs. Higher rates in this category of mixed, which is sort of a mixture of methadone maintenance and residential therapeutic communities, and higher than in the community. Now flipping that comorbidity coin and shifting into the mental health treatment settings, again here we're looking at patients who have borderline personality disorder, what they're in treatment for, and what are the rates of substance use disorders. And just to review a couple of studies here, one by Tim Truel, which was actually a review of all of the studies prior to 2000, and found that 57% of patients with borderline personality disorder meet diagnostic criteria for substance abuse or dependence, with essentially equal rates whether they are primarily alcohol or primarily drug. Very similar rates of comorbidity were found by Andy Scodel in New York. This was in a specific treatment program in New York. But almost 60% of BPD patients having a substance abuse problem. And here he did find that the rates were somewhat higher that you would have a drug diagnosis than an alcohol diagnosis. Another important piece of this is that borderline personality disorder is an independent predictor of a diagnosis of substance use disorder. And the reason that's important is because borderline does co-occur with the other Axis 2 disorder, antisocial personality disorder, which is highly associated with substance use disorders. So this is an important finding because it suggests it isn't just because borderline personality disorder and antisocial personality disorder go together, and it's really the antisocial that's raising the risk of substance use, but the borderline is its own independent predictor of that diagnosis. So there's a whole range of reasons why we focus on this pattern of comorbidity, other than the high rates of co-occurrence. I'll just talk about a couple of them. The first is that a very significant problem with suicide in this patient population, and that among borderline personality disorder patients, the three most significant risk factors of a serious suicide attempt are substance abuse, major depression, and obviously the strongest predictors of prior attempt. Another important issue is that although people with borderline personality disorder can get better with treatment, can get significantly better with treatment, and some of them get better just with the passage of time, the research tends to suggest that that does not tend to happen when there is a co-occurring substance abuse disorder that's in the picture. Some other reasons to be studying this. I talked a little bit about the prediction of suicide, but there's been a lot of research that's been done here at Yale as part of the CLIP study that Tom McGlashan, Carlos Grillo, and Chuck Samswell were involved in here, and specifically focusing on particular types of symptom constellations of BPD, so impulsivity, affective instability, and identity disturbance are very strongly associated with suicidal behaviors. And sort of as a corollary to that outcome bullet from the last slide, that patients who have borderline personality disorder at the initial assessment have a much higher, and don't have substance abuse disorder at that initial assessment. When you follow them up at 7-year follow-up, they have a much higher risk of developing a substance abuse disorder than non-BPD patients. So a couple slides on just sort of models that have attempted to kind of explain why there might be such a high rate of co-occurrence. I just want to talk about 3 different models for thinking about why these two disorders go together so commonly. The first are vulnerability models, which are essentially saying that one disorder creates risk for, or some people might say actually causes, the development of the second disorder. And then the second one, the common processes spectrum model, is that they share a kind of a common factor, and then the independent or interactive model is that they kind of feed off each other. So just a couple of more words on these. So the primary, so within the vulnerability model, consistent with comorbidity, you could argue that either the substance abuse causes the borderline personality disorder or increases the risk for it, or you could argue that it's the borderline personality disorder that's causing the substance abuse. Either one of those is a defensible opinion. The primary SUD model, which is substance abuse causing borderline personality disorder, would argue that the chronic effects of psychoactive substances on the brain and on one's lifestyle has the effect of essentially warping personality over time, and so that you can get borderline personality disorder just by the long-term chronic addiction that you're experiencing. The primary PD model would say that there's something about sort of the core impulsivity and negative affect, and that there's something about those traits that sort of causes the development of substance abuse. Either substance abuse is just one of many impulsive behaviors that borderline patients engage in, and that sort of causes it, or because of the affect dysregulation problems that they have, they seek out substances more often than others might in order to help self-medicate. The common processor spectrum model says that there's some either core trait like impulsivity or negative affect, or there's some common historical factor such as a history of childhood sexual abuse that is driving sort of both disorders. And then the pathoplasty model or independent model, there's Emily Ansell, who works here at Yale, does some work in this, says that they kind of feed off of each other. So they're independent disorders, but as they march through over time, the symptoms of one increases the symptoms of the other, and vice versa. There are also kind of less conceptual, but what I'll call artifactual or methodological reasons for why this association is so high. And this is essentially rooted in kind of the diagnostic systems that are used for these disorders. disorders. The first is, if you can bring back those list of criteria, you'll see that one of the criteria is an impulsivity criteria, and substance abuse is listed within that. And so part of the reason why they co-occur together is because they share a common important symptom. Another possible kind of diagnostic reasons is that, again, the acute and the chronic effects of substances induce changes in cognitive, emotional, identity, and relationship functioning that can really mimic a personality disorder. Another kind of artifactual reason is that co-occurring disorders may be more likely to seek treatment, and so when we do research on them, what we're getting is really kind of a biased sample of people who are having more problems. And again, if you have high base rates in the community, one disorder is about 6% in the community, the other disorder is well above 10%, 10 to 30% in the community if you look at lifetime rates. Just statistically, things are going to go together.